Let's start with Parkinson's disease. Parkinson's, by definition, is a progressive neurodegenerative disease of the brain. These are some of the known causes, but primarily it's idiopathic, meaning we have no direct evidence that a specific cause can be attributable to the development. So we just know that some of these have been implicated as possible causes of PD. So until today, that's why there's no cure for it, because we really don't know what causes it. But again, these are the um, maybe causes of Parkinson's disease. So the problem is a deterioration right here. There's a deterioration of substantia nigra. Now, this is the part of the brain responsible for the production of dopamine. If you recall, when we discussed myasthenia gravis, the problem there was we had that was an autoimmune disorder affecting the patient develops antibodies against the acetylcholine receptor sites, if you remember. The um, the problem here is different, meaning there is no problem with the receptor sites, there's no muscle weakness. The problem here is with purposeful muscle movement. Unlike also in MS, multiple sclerosis, wherein there was demyelination of the myelin sheath, um, this one is there because the substantia nigra deteriorated, so the patient has low levels of dopamine. Now, I know you remember dopamine from chapter 14 under shock, and we know we use dopamine in order to increase blood pressure in patients with specifically neurogenic shock. Um, Another purpose of dopamine is as a as a neurotransmitter. Dopamine is needed in order to coordinate muscle movement, and therefore, because its purpose is to inhibit acetylcholine. So acetylcholine is responsible for muscle movement, right? So therefore, dopamine is needed in order to control those muscle movements. So as a result, if you don't have enough dopamine, you have a lot of skeletal muscle movement with no ability to control it. So that's why the manifestations of the disease is the number one problem is resting tremors. Okay, again, there is no ability to control the movement. So the patient um, will have resting tremors, as opposed to multiple sclerosis, wherein the tremors occur when the patient attempts a movement. So this one, the tremors here are worse when they are not moving, when they are lying still. So if you recall, or if you were observant, when Michael J. Fox is anytime he's on TV doing interviews, he was constantly rocking from side to side. This is an attempt to avoid the tremors. So if he figured out that if he just keeps moving, the tremors are not as bad. So the acronym for the manifestations for Parkinson's is TRAP, TRAP. So the letter T is the tremors. Again, emphasize that they occur at rest. The R is for muscle rigidity. The A is akinesia or bradykinesia. Um, Brady is slowness of the movement, and then akinesia is loss of movement, meaning the patient can freeze. I mention this later again. And then finally, there is postural instability. Now, of course, the patient won't only have these four symptoms, but these are the um, clear clinical signs of Parkinson's that really stand out. The rest of the manifestations include they're mostly psychosocial in nature because these can affect people between 40, as young as 40 years old, up to 70 years. So, other notable personalities, of course, was the late Muhammad Ali. Neither person um, had any cognitive decline, meaning they had all their faculties, meaning they are as sharp as they once were. It's just that their body, their skeletal muscles specifically, are just not cooperating with them. Um, we will not test the stages. Okay. Let's look next at the diagnostic test. As I mentioned, the patient is usually diagnosed clinically. So similar to MS and lupus, there are tests that are done, but those tests are not used to confirm or diagnose Parkinson's, but rather to rule out other causes. Medications, this is lifelong, of course. We have a lot of medications. So the way you remember this is we have um, a problem with dopamine production because there is the deterioration of the substantia nigra, right? So therefore, our drug therapy, which is quite a few, um, they serve different purposes. One way is to give the patient dopamine in the form of levodopa. Another is to make dopamine last longer because as with any other neurotransmitter, including acetylcholine, they are always broken down. So in order for the patient to be able to increase dopamine levels is to prevent it or decrease the destruction of dopamine. So those drugs are the pramipexole and ropinirole. Anticholinergic drugs, because they are anticholinergics, so you can tell, especially this drug right here, which is very old, cogentin or benztropine, along with artane or trihexyphenidyl. These are used, as stated here, more for younger patients, because if you start giving them these to 65 years or older, they cannot tolerate these better. Plus, they may develop heart failure because, of course, anticholinergics cause water retention. And they will, of course, have these drying effects here. So you have these unpleasant side effects that always go with any anticholinergics. These are drugs I did not notice any chart, so I cannot give you a easier way to study them, but they're just found here in the paragraphs. So you know the side effects, so I can change these. For instance, instead of listing these down in a select all apply question, I can change the question into an intervention. So an intervention, of course, to manage these side effects. Okay, so let's say patients on benztropine, which of the following will you include in the plan of care or client teaching regarding this drug? All right. For pramipexole and ropinirole, if you remember in fundamentals, this was or in a previous semester, maybe you did it in MedSurg 1 maybe, under restless legs. If you remember, this drug Requip was used for restless leg syndrome. So therefore, if it can quiet, restless legs, this can also reduce the tremors of the patient. And you have side effects here for the dopamine agonist. Remember that this causes hypotension, so this will be a double whammy now. The patient with Parkinson's already has problems with hypotension because their dopamine is low. This drug will exacerbate that. All right, the problem with Parkinson's, it's a forever thing. So this is a chronic disorder which only gets worse with time. So as the disease progresses, of course, and the longer you take these medications, as with anything else that you take, any substance or medication, the patient will eventually develop tolerance to the drug, at which point they stop working. So that's why the patient will be rotated between these medications, so that they can have symptom relief. Meaning, if the, say for instance, Cinemet, which is carbidopa levodopa, um, no longer works, then um, they can switch to another medication. In worst cases, which is not mentioned in your textbook, and which is also a dangerous method, is some doctors will put the patient on what's called a drug holiday. Meaning, this is a concept they use for patients who develop tolerance to any medication, not only for Parkinson's, but several others. Let's say for pain, for instance, some pain management doctors will put the patient on a drug holiday, take them off the medication, and then so when they restart it, the drug will start having effects again. If you remember, we discussed the concept of the blood-brain barrier. Okay, so far these drugs do not really affect, I mean, their action is not on the brain, except levodopa. Now levodopa is dopamine, but as you can see, there is the blood-brain barrier causes levodopa. This drug can cross, but the drug though gets destroyed as it crosses, meaning as it gets into the brain circulation. Levodopa, which is dopamine, is easily destroyed. So to prevent that, they will give the patient carbidopa levodopa instead, because carbidopa levodopa is now a dopamine precursor, meaning this is not dopamine yet. So carbidopa will allow levodopa to be transported without being converted to dopamine yet. So as a result, it will not be destroyed. End result is, of course, it will last longer. Okay, so levodopa itself is, as stated here, is less effective. Okay, so the Cinemet, which is the most common drug mostly given to Parkinson's patients, it works better. As I said, these patients will develop tolerance eventually. So the patient will have freezing episodes. These are the off episodes, meaning the drugs don't work anymore. So this is dangerous because, as you can see, the patient has, look at the manifestations here. Right, so the mask-like facie, meaning plus the tremors, puts this patient at risk for aspiration, because not only will chewing be affected, but also swallowing. Um, they have this slow shuffling gait. The best way I can describe this is, I can't demonstrate it obviously. um, Imagine your feet being like there's magnets under your shoes, okay, and then you're on a metal surface. So the patient will attempt to lift their foot to walk, and it seems like it's glued to the floor. No, they can't move it. So that's the and then when they finally get to do it, one foot after the other, it results in a shuffling gait. Okay, or sometimes um like they can't step at all. Okay, so it's like the the feet are glued or stuck to the floor, and that of course will put them at risk for falls. Here are your Here's the purpose for Cinemet. Of course, that is effective with the symptoms of um, Parkinson's. Okay, and then these are the side effects that follow. Surgery. Surgery is only done for relief of symptoms. Again, there's no, um, shall we say, cure for Parkinson's. You can only manage the disease. Okay, make you last longer, prevent you from having, um, from dying from aspiration, for instance. But of course, uh, we can only treat it for so long. But if managed properly, you saw Muhammad Ali, he grew old, right? And Michael J. Fox has had it for a while, and he also grew old. But I really have no questions on surgery. I mean, it doesn't really um, cure the disease. All right, here we are with nursing management. Here's a summary of your signs and symptoms. Now um, okay, so signs and symptoms, of course, these are what you assess. Okay, the trap. So our goal here, of course, is to keep the patient safe, keep them comfortable, protect them from the um, complications that may result from the symptoms. All right, so again, medications. Teach them about the side effects, especially about the hypotension, and warn them about the tolerance that will result in those off episodes, or they no longer work. We implement safety, of course. These people are at full risk. These patients actually, you'll be surprised how many Parkinson's patients live alone. And these patients are managed, of course, at the home by a home health nurse, a visiting nurse, or sometimes they may come to a point wherein they'll require um, um, assistance with ADLs. Facilitate nutritional intake. Okay, so again, makes not only chewing but also swallowing, and even talking will be a chore. Um, so this is part of your aspiration precautions. This one too, the suction. Stool softeners, because we did mention here the patient has constipation. If not from the drugs, it's also from the immobility that results from the disorder. Another thing is, of course, self-care as much as possible. Um, Physical therapy will improve, as well as OT, and especially speech therapy, which not only improves communication, but also with swallowing. As I already mentioned earlier, these patients are cognitively intact, meaning, um, and they tend to isolate themselves socially, because you go from, imagine you're Michael J. Fox, and then all of a sudden now you can't work because you have these tremors, you have this weird way of walking, this mask-like face C, meaning you have no more facial expressions, you have this blank um, look on your face. That can cause depression. Now, these patients, although there are some Parkinson's disease patients that develop dementia, that is not that dementia is not part of Parkinson's, meaning they develop dementia because they had a risk for dementia, but not Parkinson's is not going to cause dementia. Meaning these patients are cognitively intact, they are totally there, and that is the cause of why they will develop depression, just like what happened in MS. Okay, teaching, of course, medication compliance, safety, and put them, in support groups. These are chronic conditions, so um, we take care of the caregiver also, just like what you learned in dementia, Alzheimer's dementia, caregivers. So those patients will also require respite care. Okay, so otherwise, the patient might outlive the caregiver. The caregiver will work themselves to death taking care of these patients.